Well, good evening, America. You are in the right place. It is top of the hour, 5 o'clock on the Gulf Coast, which means 6 o'clock on the East, 3 o'clock on the 6 o'clock in the East. Yes, 3 o'clock in the West, 4 o'clock in the mountains. And I'm Dr. Randy Fink. This is Fertility with Fink, our weekly place to get together and talk about all those things that are important, things about women's health, things about fertility, things about making a family, things about getting pregnant, staying pregnant, and all things about being happy in our lives. Thanks so much for being here. I am live tonight from Pensacola, Florida, where I am a fertility gynecologist here at New Life Fertility. We also have offices in Panama City and in Mobile, Alabama. We see patients from all over this beautiful country. I am also on the staff at the Missouri Center for Reproductive Medicine, MCRM, in St. Louis and in Tulsa. Also happy to see folks from all over this great nation of ours, not just the Southeast, not just the Midwest. We are here for you. We are part of the world-renowned First Fertility Network, and really, you know what? This is my favorite place to be every Tuesday night at this time. So thanks so much for joining. How's everybody? How was your weekend? How's your week so far? We've got exciting things going on for a lot of folks. I see Amber has joined from Gulf Shores, and Amber has definitely some exciting things. I will leave it to you if you'd like to share that. Oh, a very, very special shout out here to Kaylin in Amarillo, Texas, who has joined me with her hat. Thank you, Cowgirl, for being here. You are very, very missed, my friend, for sure. Hey, Beth, Rosa, thank you for your kind words. Jazzy Poo, good evening to you. The Daverly, Nia Amor, Abbas Barnett, you are the first to join over here on my Instagram side, and that's Randy Fink, MD. We also have New Life Fertility's Instagram. Right here in the middle, we have Facebook and YouTube, and a couple of different Facebooks, New Lifes and MCRMs. We've got LinkedIn and a couple of different YouTube feeds here as well. So I am here for you tonight to talk about all those things that are important. All your questions, please throw them my way, because that's what we do. Or if you just have some thoughts to share, we'd love to hear that stuff too. Disney Stuff with Matt, good evening. Thank you for being here. And Katie, looks like Katie B doing things. We got a bunch of folks over here on the Facebook side. Nobody has said anything to me yet. So, well, I will tell you, it's been a little chilly here on the Gulf Coast. It's about 62 degrees outside right now. And you'd say 62 degrees, that is a summer afternoon for a lot of folks right now who are dealing with the frigid cold. This coming weekend am going to be going back to Colorado, which is where I was just before I came here to the Florida Panhandle. And I'm not so sure that I am really looking forward to being back in that cold, because very quickly you get used to not being in the cold. But, it was, I think it was, it was the upper 20s here, 28, 27 degrees, I think, in the morning. So we had some good cold here as well, but not quite the same as the ice storms affecting so much of the country here. Excuse me. This wonderful cup, I will say thank you to Melissa for introducing this cup into my life. I do appreciate that. It was a wonderful gift and is very appreciated. Oh, let's see what else we've got going on here. Amber Jones. Okay, so she is going to share her news. Positive beta yesterday, thanks to Modified Natural Protocol with Dr. Finkster. Yes, well, thank you very much. So what happens after you get that positive pregnancy test, and really what exactly is happening? So in our practice here, when we do an embryo transfer, we are doing that transfer really about a week after, in a modified natural, a week after, excuse me, after a trigger shot. So that would otherwise be the kind of time that you would be ovulating. That would be the time that your ovary would be releasing the egg. And then 7 days after that transfer is when we are doing your beta HCG. And that's really going to be the very earliest time that we should expect to get a positive pregnancy test, even though many people will contact me and they'll say, oh, I'm so disappointed. I did a pregnancy test at home and it was negative. Well, guess what? A week, 1 week, 7 days after a blastocyst embryo transfer, I wouldn't expect a urine test to be positive because you really need a quantitative beta HCG of about, call it about 50 before maybe even 35, 40, but 50 reliably so is the threshold at which a urine pregnancy test will become positive. And 7 days afterwards, I expect, really honestly, anywhere between, depends on when the embryo implanted, anywhere between a 5 and a 20, because it has just barely implanted and started to secrete that pregnancy hormone. So in the case of our early positive pregnancy tests, as we saw yesterday with Amber, we see that number being very low, as is expected. Now, if let's say, 2 weeks, 10 to 14 days, for instance, after doing an embryo transfer, if we find that your beta is 20, then I would say, all right, well, that doesn't sound very reassuring because it really should have implanted probably a week ago. 20 is really about where is the upper ends of where I expect it to be. So that's very, very reassuring 7 days after an embryo transfer. What do we do next? Well, next we repeat that beta in 48 hours. Why is it 48 hours? Why do we do that? Well, we do that because the beta HCG will double in about 2/3 of the cases. We want to see that number going up. Now, in some places, they do with natural cycles, they will do what's known as an HCG booster. And that's where you get a little bit of the HCG pregnancy hormone, usually 250 units, and you inject that sub-Q every day, because what it does is that it converts in your body to more progesterone. Right. And progesterone is the hormone that your body needs in order to maintain a pregnancy. Well, if you're short on progesterone or you need a little more progesterone, you can do that HCG booster. But when you put an HCG booster in, what do you suppose happens when you check HCG in your blood? Of course, it's going to be positive because you're putting it into your bloodstream and then you're drawing some blood and looking for it in the bloodstream. So, yep, if you're using an HCG booster, that will give you a positive pregnancy test, even though the pregnancy may not be secreting that pregnancy hormone. That therein, in that situation, we we look for that number to go up on the second draw because if it's a pregnancy that's secreting the hormone, that number will be going up. But without the HCG booster, 20 is about where is top of where I really expected to be on that first pregnancy test, and hopefully then when we repeat it 48 hours later, it just keeps going. That's what we're looking for. By the time we reach a threshold HCG level of about 1,500. At 1,500 to 2,000 or so is where we should expect to be able to do a vaginal ultrasound and see the pregnancy inside the uterus. That's what we call our threshold level. We should be able to definitively diagnose an intrauterine pregnancy when that beta HCG is between 1,500 and 2,000. But do we rush to do that right away? Not necessarily, because it's not going to be until, really between 6 to 7 weeks that we can look to see that heartbeat. And the heartbeat is the most important thing that we can see. Because once we look and we see that heartbeat, we know that 95% of those pregnancies are going to continue to grow. So to do a bunch of ultrasounds before that in people, well, it probably just creates more and more and more anxiety, because every time you look, you're worried, and you're not necessarily getting more information. So usually we like to see that number doubling. We might do another one again and make sure it's still going up. But ultimately, by the time you're about 6 weeks, a little after 6 weeks, that's when we will do a viability ultrasound, do an ultrasound to be able to see that pregnancy inside the uterus and see the heartbeat. So that's the good news. Hey, to all my friends up at MCRM. Thank you for the kind words. Lisa, thank you for being here this evening. I appreciate that. We've got Holly Jolly here who asks, is it normal to not have a positive OPK on cycle day 22 with a 35-day cycle? So first thing I'll tell you is that the urine ovulation predictor kits are notoriously inaccurate. They're hard to use because they're really predicated on a certain amount of HCG, or I'm sorry, a certain amount of LH, so luteinizing hormone, showing up in your urine. So you're peeing on a stick or you're peeing in a cup and you're dipping it in. And the thing is, well, it just depends on how much urine is in your bladder, because it may dilute it out to the point where you just miss it. Or it may show you that you've got an elevating level of the LH hormone, but it may never peak because some people just really don't peak. I think they're really hard to use. So if somebody tells me that, well, first of all, I wonder in a 35-day cycle, are you actually ovulating? If you're really ovulating if you're really ovulating and you have a 35-day period, then usually that would mean 14, 6, 7, 21, 22 is around the time that you should be ovulating. That's when we would expect to see a positive OPK, or if we're doing basal body temperature measurements or so. So, again, it's just, Holly, it's tough to use the ovulation predictor kits to be precise. So I like to use that in combination with some hormone levels and with an ultrasound where we can actually look in your ovaries. Sometimes we'll also even trigger the ovulation, so we make sure that your ovary is releasing the egg at a predictable time so that you can get sperm where it needs to be. Now, optimally, sperm will get there before the egg is released. That's really what we're after. So even if you're not sure, I would say if you're able to get the sperm there around that time, then that sperm will live inside of you for about 5 days or so. So that really hopefully should be sufficient. Misha is here and says, I was supposed to be transferring tomorrow at the Pensacola location, but it was canceled. And now it's confusing. And now I'm needing to have my birth control device removed, which is an Essure. How long would it take for the uterus to heal after having the Essure removal procedure? Okay, I know what you're talking about. So the issue there is that, and I don't want to, Misha, I don't want to go into too much personal information here, because we've just, kind of put your name out there, and I don't want to talk too much about your kind of personal history. But let's talk in generalities. Essure was a device that was used for permanent sterilization. So when somebody wanted to have their tubes tied, what we typically would do is sometimes you could do it postpartum, so before you even left the hospital, and we would make a small incision just below the belly button and could tie the tubes that way. More commonly, we would do a laparoscopic tubal ligation, which is where you go under general anesthesia and a little camera goes in through your belly button. We take a look around and we can either remove the tubes entirely or pull up a little knot of tissue and remove that, put some suture around it so that as it heals, it leaves behind a little space between the two ends of the tubes so that they're not connected. And if they're not connected, then that is a roadblock such that sperm will not be able to reach egg. And that's what a tubal ligation is. Well, the Essure procedure was a little metallic coil. It was usually made of a combination of nickel titanium, and through a hysteroscope, so basically in a camera that went through the cervix. Typically, an Essure procedure is done in the office. It did not require general anesthesia. In capable hands, it could be done very, very quickly, where this little device was placed into the opening of the fallopian tube. And then over the course of about 3 months, the body would heal over it. It would create some scar tissue over this little piece of nickel titanium. And that scar tissue would then block the tubes so that there was no way for sperm to be able to reach egg. The recommendation was that at the 3-month mark that you did an HSG test, the dye test, to make sure that the tubes were indeed blocked. So the problem there with the eShore procedure was that in many cases, those little nickel titanium coils could migrate. And sometimes we will see someone coming in for for an embryo transfer, and lo and behold, we look at an ultrasound, and it looks like there's a coil sitting right in the middle of their uterine cavity. And you say, how in the hell did that happen? Because it may be after you did the procedure, you had enough documentation, you had ultrasounds, you maybe even did the HSG and showed that, yeah, the coil is where it's supposed to be. But over time, those coils can move, the coils can migrate to the wrong place. They can migrate into the muscle of the uterus. And one of the other problems with the eShore procedure is that they had a lot of doctors who were performing the procedure who may not have been as comfortable doing hysteroscopic type procedures. And so it may not have always been done correctly. But the question is that if there is, or I should say, if there's a question as to where is the location of that implant, then we want to know that it's not sticking into the uterine cavity, because then if you try to go do something like place an embryo on the inside, it can cause you the embryo not to be able to implant. Now, it's difficult to remove those little coils because there's scarring over them, and it's not just a question of, oh, just zip pull it out, because it's pretty scarred down in there. So you kind of have to have someone who's a specialist in being able to remove those, or who has experience in removing them. So Misha, I wasn't aware that your transfer was going to be canceled, but really I think that it just depends on where it turns out that coil is and how much it was sticking into the cavity, or how much, if it was in the cavity there, how much digging had to be done in order to kind of be able to get it out. But most of the time, certainly I would think in the very next cycle, I would expect you to be able to do an embryo transfer. At worst case scenario, 2 months. It shouldn't really be that long, because those little implants were not very big. They're pretty small. And so removing them shouldn't be too traumatic to the endometrium. Hey there to Aaron. Nice that you were able to join from wherever it is you are tonight. Thank you for being here. We've got GPTV, and Rosa, my friend, asks, my MRI before pregnancy reported my ovarian cyst as an endometrioma, and an ultrasound yesterday said the same cyst as a hemorrhagic corpus luteum after pregnancy and breastfeeding. Why the different report? I think, Rosa, you are known to have an endometrioma there. So the thing is that an endometrioma and a hemorrhagic cyst can really look very similar, or even the same, by ultrasound. So if a radiologist is looking at an ultrasound and sees the presence of a bunch of sort of clotted blood, well, that's really what endometriosis looks like as well. And so without benefit of having seen your previous imaging, they may just say that it's a hemorrhagic cyst. Rosa, we knew that was endometriosis in you. It had been there for some time. I know we've talked about it a number of times. So I think that probably is just a little error coming from the radiologist, who said, well, it looks like a hemorrhagic cyst. That's in the differential diagnosis. So is an endometrioma. But they didn't have any of your other films to compare, because if they had looked back and seen this same thing having been there, a year and a half ago, 2 years ago, they say, oh, clearly that's an endometrioma. So I believe that's probably what happened there. Desi, nice to see you. Hey, baby love, Zenaida in South Florida. Good evening to you. Bama Gal, which is my mama in Mobile, Alabama, is here tonight, along with my dad by her side. They watch every week, and I'm very appreciative of that. That is when they can figure out how to get on the computer, and they call me on the phone. They say, that That fertilizer with Fink thing that you do. And I say, that's not fertilizer, it's fertility. Fertility with Fink. Oh, right. Yes, that's what I meant to say. Yeah, because I got a lot of fertilizer going on over here on this end. Thank you very much. But I come by it honestly because it comes from you, mom and dad, that fertilizer. Yep. So let's see what else here. Hopefully, Rosa, that answers your question. MRI is really an excellent means of evaluating a cyst, but we know that that's what that was. Same size, about the same. I wouldn't have expected for it to change too much. Let's see. Baby Love says, after an ultrasound today, it's protruding into the left side of the uterus. What does that mean? Let's see. Did I miss something up here? Um, hmm. Well, Baby Love, there you are saying that something is protruding into the left side of the uterus, but I'm not sure what you're talking about here today. All right, Pensacola Wellness, good evening to you and Angela. Hi, Angela Sack. Thank you for being here. Oh, the eSure device. That's what you're talking about. Okay. All right. So now we're switching platform. You're confusing me. How can you say that? All right. So you had an ultrasound today that said the the eSure device is protruding into the jump from Instagram to from Facebook. Yeah, you did. You're just trying to confuse me there. That ain't right, friend. Jeez, man, you're hurting me here. Boy, I'm working up a sweat tonight. Gosh. The ultrasound said that the eSure is sticking into the left side. What did you say here? To the protruding into the left side of the uterus. Well, as long as it's not in the cavity, muscular portion of the uterus, then it's not likely to have any effect. I think the question is, or at least the question was in your situation, where is it and how much of it might be affecting the uterine cavity? Because when it's in the uterine cavity, that's the place that the baby is going to use to implant. That's where the placenta is going to grow. That's where all the blood supply is going to be that supplies the baby. So it really, I think, is probably the question. All right, let's see what else Lisa says. Miss you in St. Louis. Can't wait to see you again. And I can't wait to be there, although I wish I could bring a little bit of Florida with me. My goodness. So I will be back in St. Louis, I think, for 3 days on the 19th, I believe, for the next egg retrievals up at MCRM in St. Louis. And I will be there to help. So if you're in the neighborhood, please do stop by and see us, or call MCRM. I'm happy to talk to you through there. Depends on where you live. Shada is here. Hello, my friend. Haven't seen you for a while. Could you remind me how to schedule an appointment? Well, I'm glad you mentioned that. So here in Florida at New Life Fertility, our website is fertilityleaders.com, and that's got the phone number for New Life Fertility. Happy to schedule to see you virtually through New Life, or for that matter, through MCRM, and that's the Missouri Center for Reproductive Medicine, located in St. Louis and in Tulsa. So either one, whichever is most convenient for you, we are here for you, my friend. Let's see. Holly asks, will progesterone help before pregnancy if you are low? Okay, so last month, Holly asked before about the positive OPK on cycle day 22. Last month, you got the positive on cycle day 19. So what happens with folks is that there are two parts of the menstrual cycle, the first half and the second half, and they're not always half. But if you have a 28-day cycle, all right, then typically the first portion, or what we call the secretory portion, the proliferative portion of the cycle, the first half of the cycle, that's when your estrogen is making the uterine lining grow. It's making it proliferate. That time can be variable in people. In a 28-day cycle, it's about 14 days. Then you ovulate, you release your egg. From the time that you release your egg until the time you get your period is almost always going to be 14 days. So the first part of the cycle, the proliferative portion, can be variable, but the second half, which is what we call the luteal phase, is almost always 14 days. And so you should be able to say, look at when you got your positive OPK, and 14 days after that, about roughly, should be when you get your period. So you're using 10 milligrams of letrozole for ovulation induction. That's a good thing. Progesterone really doesn't need to be there and should not be there until after you ovulate. So when your ovary releases its egg, that space that was making your estrogen before, that was causing the lining of the uterus to grow or proliferate, as we said before, that little estrogen factory becomes a little progesterone making factory, and that's known as a corpus luteum. The corpus luteum is the cyst in the ovary where the cells that were making estrogen are now making progesterone. So if you make progesterone before you release your egg, it's going to spoil the endometrium. It should not be there. So no, progesterone before ovulation is not helpful. It is harmful. It will keep you from getting pregnant. But then once you release the egg, your body starts making the progesterone. You make that progesterone, so getting some extra progesterone at that time may be helpful to you. Your body's making plenty enough of it, but we like to sometimes use some vaginal progesterone as a little supplement because the vaginal progesterone isn't absorbed into your blood. It's not going to show up in your blood test at all. Rather, what it's doing is just a local effect on the lining of the uterus. And what does it do to the lining of the uterus? It starts to compact that lining. It changes its appearance on ultrasound and it makes it more compact so that it's ready to be a nice, spongy, warm, tight, juicy place for your embryo to implant and for your baby to grow. So yes, we do often use a little extra progesterone to support the endometrium in the luteal phase of the pregnancy. Now, not every time. You don't necessarily always need it, especially for folks who have polycystic ovarian syndrome. We know that giving you some extra progesterone in that luteal phase of your cycle after ovulation induction can help, and it can also decrease the risk of miscarriage. Now, let's talk about those progesterone levels because that is something that I hear about from people often. And that is, they say, well, my progesterone was low, and that's why I had a miscarriage. And I would tell you, it probably did not work like that. Low progesterone doesn't cause a miscarriage, but rather an unhealthy pregnancy will cause you to have a low progesterone. So again, giving you a little extra progesterone can help to maintain things. It can help to make a healthier environment for the pregnancy, but your body is usually making plenty good. So a special hello to Patricia tonight from the west coast of Florida. Thank you for being here. Boy, I haven't seen you for a while, but it sure is a pleasure and an honor that you would drop in on us tonight. It's about half past the hour, which means it's time for the 5:30 Fuzzies with Fink. What is that? Fuzzy Fink, I don't like the sound of it. The 5:30 Fuzzies with Fink is the chance that we take right now, all of us, to get together as one and to send out positive vibes to everyone tonight who needs it. Who needs it? Well, if you're going through a fertility thing, you know that you could use it. And I always say, I think that everybody who is on this podcast, the folks who listen here, are the kind of people who would really give the shirts off their back to be able to help other people who are in need. People who are lonely, people who are scared, people who don't know what's going to happen tomorrow with a test, people who are worried that maybe they won't be able to have a baby. But it's not just about fertility. It's about relationships. It's about family. It's about school. It's about the workplace. All those things that create stresses in our lives can make us feel very much alone, isolated, without people you feel without people to talk to, and that makes that emptiness seem even larger. So, what I like to do at this moment is for us all to be together, to stand together as one community, and to reach out to everybody out there who just needs to know that someone is listening and that you're not alone. That's what we do at 5:30 every week. The 5:30 Fuzzies with Fink is to break the internet with kindness, because there is not enough kindness in this world. So let's do that for each other now. Here it is. Thank you so much for participating. Think those fine, fine thoughts, because tomorrow is a new day full of all new adventures. All right. If you just joined, I appreciate you being here. It's a little bit beyond half past the hour. That was the 5:30 Fuzzies with Fink. I'm Dr. Randy Fink from New Life Fertility in Pensacola, Florida, and MCRM, the Missouri Center for Reproductive Medicine in St. Louis and Tulsa. We are part of the world-renowned First Fertility Network, and it is a pleasure to be here with you tonight, here to answer all your questions. So throw them my way, would you? So let's see what else we had there. Robin says, can I take minoxidil while suppressing for endometriosis and then while prepping for transfer? I would not recommend it. I would not recommend it. While you're suppressing for endometriosis, I'd say yes, you can be on some minoxidil, but oral minoxidil or systemic minoxidil while getting ready for an embryo transfer, I would not suggest. A special shout out to Brandis. Good evening. Thank you for being here. Brandis was my friend from Colorado Springs and my former place of employment. And it's an honor to have you here tonight, my friend. Ariel is here and says, can low iron affect fertility? And the answer is yes, it can. So anemia is one of the things that we look for when we do your baseline laboratories, because the question is always, well, why is it that you're anemic? What's happening there? So some people get anemic because they have very heavy periods. Sometimes it's because the blood loss results in your blood count being too low. That's something that I always want to correct, because that anemia can have an effect on your egg quality. It can also sort of have a negative feedback into your thyroid, which affects, really all your hormones. But so is it because of blood loss? Is it because of I've honestly, we've found colon cancers, believe it or not, in folks who came for fertility evaluation because of losing blood through the colon from a polyp or something that's bleeding inside the colon. So, is it because of something genetic? Is it because of not being able to absorb your iron? Is it because of a B12 or a folate deficiency? All these things can be a cause of anemia. So, yeah, we like to know that you're not anemic, and if you are, we like to just figure out why. So taking a little extra iron, especially if you're anemic from the blood loss, can have an affirmative difference on pregnancy. Yes, indeed. How long does an HCG wash stay in your system? So the HCG wash is when we take some pregnancy hormone, HCG, and place it in a syringe on a little straw and place some of that fluid inside the uterine cavity. And what that does is that it's placing the pregnancy hormone directly on the uterine lining so that it has a chance to kind of turn up some of the receptors on the inside for pregnancy. It does what we call upregulation, which is a good thing as it pertains to the pregnancy receptors. But that HCG wash is like putting it's like putting hand cream on your hands. You're not getting systemic levels of hand cream when you're putting some moisturizer on, right? So the HCG is really doing the same thing. It's just treating the lining of the uterus, and that uterine lining, you may absorb a very little bit of it, but it should not be enough to affect a pregnancy test, a week or 10 days or however long after your embryo transfer. It should be long gone by then. Really, again, just think of it as a topical solution, something that's just going onto the skin of the inside of the uterus and should not really be absorbed into your body. Oh, today was a big day. We did about 14 embryo transfers over here with me today, and I was wearing a little headlight, and I can still see I've got what looks like a cyclops eye there. Maybe I should start wearing makeup just to make myself feel pretty. But then, if I'm going to put on makeup, then I'm going to want to wear a wig, and the thing with the sequins and all that, and it just gets to be a big production. It gets to be tough. Hi, Sir Kip. And let's see what else we've got. I think we saw a couple of other questions over here coming from the Facebook side of things. What can help with a low AMH? So AMH is your anti-Mullerian hormone, and it is the marker that we use for ovarian reserve. Now, AMH is a reflection only really of, well, all right, how much medication are we going to need to use in order to try to stimulate your ovaries to get them to give us eggs? It is not a reflection of, are you going to be able to get pregnant? It is not a reflection of when are you going to go into menopause. It's none of those things. But since you, as a female, are born with every egg that you will ever have, over the course of our lives, we lose those eggs. Right? We lose them to the process of aging. Not only that, the DNA that's in those eggs becomes less stable, which results in those eggs not being able to produce normal offspring. But as we mature and the eggs start to go away, there needs to be a reliable way to kind of be able to look at them and say, well, what do I have going on here? Every one of those little eggs in your ovaries is surrounded by some cells. And these cells secrete a hormone that's called AMH, anti-Mullerian hormone. So so the more eggs you have, the more of those cells you have, and the more of those cells you have, the more AMH you make. So we can test that amount of hormone in your bloodstream and really plot you out on a graph and see where you are relative to other people who are your age. That's what the AMH is really for. And when that number is low, it's reflecting the what we call the egg reserve. And since all those eggs are there from the day you're born, we are not at a place in science yet where we can place more eggs inside of you. The AMH really is what it is. We don't have the ability to be able to alter that number. Now, what we can do is to try to do things to improve the quality of the eggs that you do have. And by egg quality, I mean, well, what about the stability of the DNA that's in those eggs? Because that's another thing that suffers as we mature. So we know that if your AMH is low, it likely means that we're going to be limited in the number of eggs that we're able to retrieve. But if we make every egg count by doing things to improve your egg quality, that's the best thing that we can do. So what can you do to improve egg quality? Well, certainly clean eating probably helps. If you smoke, stop smoking, some kind of common sense things like that. There is an evidence-based supplement protocol about which I even wrote a book, and I'm happy to send. Actually, the link for that is on my Instagram page at Randy Fink MD. It's called a link tree, and you can just click on that link, and $7 is the ebook, and that will give you the whole supplement protocol for actually really everything that we do in fertility, all of the evidence-based interventions that you can make. And I think that's a good thing because I do think that those vitamins make a difference. Now, there is a lot of noise out there about vitamins, and especially if you Google what should I take for pregnancy? The problem is with Google, everybody's trying to sell you something. And so there's going to be, lots and lots of junk on there about this vitamin and that vitamin, and this helps fertility and that helps fertility. And, the truth is there is an evidence-based approach, and that's what I would encourage you to follow. There's another great book out there about that that's called It Starts with the Egg, that can be bought off Amazon, that really kind of goes into some deeper detail about some of these things. But so the supplement list, I think, is a very good thing. Omnitrope is growth hormone, and we talk a lot about omnitrope as maybe being something that helps some people with egg quality, although that is debatable. There are some studies that show it does wonderful things, and there are other studies that show it doesn't do anything at all. So it's expensive. We're paying more attention now to a medication that's called sirolimus. Sirolimus. And sirolimus is also known, the brand name for that is called rapamycin. And I am starting to use this in folks who I know will have or who do have egg quality issues, because the evidence is pretty good that in certain cohorts of people, it can improve both the number of highly graded embryos and the live birth rate by simply taking one pill a day for roughly about a month. So I'm using sirolimus now and find that it is useful for egg quality. So egg quality is really what I would say, Holly, we want to kind of try to focus on. Alizy says, my husband had a vasectomy reversal 2 years ago, but it's now obstructed. What kind of interventions can MCRM do to retrieve his sperm? So when a man has had a vasectomy, he's still producing, in most cases, lots and lots of sperm. The problem is that there's the blockade. So there's no exit for that sperm. There's nowhere for them. There's no way for them to be able to get out. And so what happens is that we do an aspiration from the testicle, which is we place some numbing medicine in the testicle and actually remove sperm directly from the testicle. That's called a TESA, and that is an extremely effective way of doing it. Here at New Life, our Dr. Rips, my partner here, does that procedure himself at MCRM. It's a urologist who performs that procedure. And so we can certainly refer you to get some more information about that. But that's really how it's done. We're able to get some sperm and able to absolutely work with that sperm. Typically, there's some blood tests and things that we do ahead of time. We want to make sure that the body is still making sperm, because there are situations, for example, let's say that the man is using testosterone. Well, if you use testosterone, it's going to shut down your sperm production. And so we don't just want to conclude that there's zero in the semen analysis because the vasectomy. We want to check some hormone levels and make sure that he is, in fact, still making sperm, because that's kind of an important thing to know. But yep, Alizy, there is absolutely stuff to do for that. That's an easy one. That kind of problem I like, because we can solve it pretty fast. Let's see, we've got Hunter Jackson over here as well. Good evening, and thanks for being here tonight. Let's see. Emily, hello, and a very special greeting to Miss Angela up in Minneapolis. The chief of, let's say, the chief of broken hearts. How about that? Angela's a wonderful nurse practitioner in the cardiac arena who takes care of people with broken hearts. And you are a heaven-sent person for being able to do what you do. And so we all appreciate you. Boy, the folks in Minneapolis are having a hard time. It doesn't take much to look at the news and see what's going on. Our thoughts go out to you and all your friends and colleagues, especially at the VA, where you lost a colleague to a shooting not too long ago. My hope for our world is that it quickly becomes a happier and easier place for us all to be, you know? Let's see. I got another question from this came through the email. And by the way, if you have a question and you can't get to me through the program here tonight, feel free to email that. And that's Ask Fertility with Fink at firstfertility.com. Ask Fertility with Fink at firstfertility.com, and we will get to your question in the next next show. The question was, does sperm always live inside of me for up to 5 days? And I would say, up to 5 days is the important feature there, because is it always exactly 5 days? Well, certainly, the sperm count will start to diminish. Some of it comes out. But that's one of the reasons I think we can say pretty definitively that, we are fairly inefficient at the way we reproduce. It only takes one sperm to get the job done. Only takes one sperm. But in order to reliably get that one sperm on target, we need at least 20 million sperm to get there. Why is that? Well, did you know that 96% of our sperm are abnormal in the way they appear? And when they're abnormal in the way they appear, they may also be abnormal in the way that they function. And so, therefore, if 4% normal sperm is normal, then gosh, maybe that's a good reason that you need 20 million in order to put one sperm on target. But one sperm is really all it takes. So sometimes folks will come in and they will have, let's say, a lower sperm count. Let's say that they may have a sperm count of about, I'll call it 5 million sperm. Well, 5 million is still an awful lot of sperm. It's 5 million. And if you only need one to get the job done, 5 million ought to do it. Well, and it might, but the question is, when is it going to happen? Because we know with a normal sperm count, couples with appropriately timed intercourse, 85% of those couples will conceive within a year. Now, if the sperm count is 5 million, again, only takes one sperm to get there, but how long is it going to take? Is it going to be next month? Is it going to be 5 years from now? Can't say. Might it get there on its own? Might it not? Yeah, we just never really know. And so that's one of the reasons that folks sometimes come in and ask for help. But the question here was, is 5 days the amount of time that sperm stays inside? And the answer is yes. There's pretty good, we can look inside of you 5 days later and still probably can find motile or swimming sperm. Now, there may not be a ton of them, but sperm is still there. Sperm do better when they are there, when the egg is released. And so the more important feature is getting that sperm there before you ovulate, because if you can do that, call it 12 hours or 6 hours before you've released the egg, there's going to be plenty enough sperm there to hopefully be able to go and try to get on target. Ariel asks, can someone with mobility issues still do an IUI, or do they have to go directly to IVF? So you said the question you're asking is mobility. And so I'm thinking that you mean mobility. So can someone who is, let's say, wheelchair bound still do ovulation induction with an IUI? And the answer is yes, absolutely you can. Absolutely you can. In most cases, folks who are paralyzed still have the same, I will say in most cases, I'm not sure I can generalize that, but in many cases still have the same functioning anatomy. The sperm and egg still can meet one another in a normal way. And so people absolutely have the capacity to get pregnant like that. So no, IVF is not required. Folks with mobility issues can definitely still do IUI. Recently found out, Amber says, that TRT, that's testosterone replacement, over time can kill sperm count. Is there anything else that does that, I'd like to educate my sons. Well, it's a great thing to bring up there. And the issue is, okay, so a lot of kids in school, particularly, athletes, um, start experimenting with steroids. And they may be told, because they're oftentimes getting these steroids from a friend who may be getting them, who knows where. So you don't necessarily really know what they are injecting there. But here's the thing. So let's say a guy of normal reproductive age who wants to get pregnant goes on testosterone therapy. So I am fond of saying that we as men are lazy down to the cellular level. Those cells that make sperm are the same cells that make testosterone. And so if we get some testosterone from the outside, those cells are going to say, dude, you're getting testosterone from someplace else. We're taking a nap. And so they go to sleep and they may not wake back up. But as they shut off making the testosterone, they also shut off making the sperm. And it may or may not recover. Sometimes it does and it recovers great, but sometimes it just doesn't. So it really depends on the individual. So guys that are, let's say, weightlifting or athletes as teenagers who start experimenting with steroid use typically do so because they're trying to bulk up, they're trying to be more athletic, they're trying to usually put on muscle mass typically, and be able to perform better at the gym or in their chosen sport. That's the sort of thing that can sort of ding the testicles very quickly, and especially when happening at such a young age, they just may not really recover. They will probably go back to making some testosterone of their own. It just depends on how long they're on it, but the sperm part may just not come back. Are there other things that do that same kind of thing? That's really the most important one, and the thing that, a lot of pediatricians who are astute want to counsel their teenage males about, that messing with steroids has a lifelong consequence. It can absolutely not only affect the testicles, but it affects the heart, it affects the liver, and really can have adverse effect on lots of different parts of the body. So it's steroid use, Amber, is what you want to counsel them about. Yep, keep away. I got my period 5 days after my positive OPK last month. 5 days after a positive OPK, and I had my OPK on cycle day 19. Well, that's interesting, because I would expect, again, 14 days after ovulation before you get a period. So that suggests to me either something's not right in terms of the way you're ovulating, or that can be something that we call a luteal phase defect. And that's where that corpus luteum, and that's the little area of cells that manufacture your progesterone, are giving out too early. They're quitting before their job is done. So I would suggest, that's certainly probably something, Holly, worth looking into. Can losing weight help a sperm count? The answer is yes. Male obesity is associated with lower sperm counts. And so not only lower sperm count, but potentially also global fertilization impairment. So now I will be honest with you, in my practice, I don't really feel like we should be paying too much attention necessarily to weight. In folks who have a BMI that's greater than 40, I will help them lose weight with the GLP-1 medications, because in order to do something like IVF, in order to do IVF in the state of Florida, you have to have in this sort of surgery center, you have to have a BMI that is body mass index that's less than 40. So I will certainly help people with that. But from a sperm standpoint, really, again, all we need is one sperm in order to get there. But to answer your question, yes, it does make a difference, or it can make a difference. The American Society for Reproductive Medicine says that it is neither scientifically based nor ethical for us to withhold treatment to anyone based on their weight. And so I absolutely don't. People have a right to get pregnant at whatever state their lives may be. And now, I will always counsel with the understanding that, well, once you're pregnant, we don't lose weight in pregnancy, right? It doesn't miraculously just fall off as soon as we get pregnant. We're only going to gain weight in pregnancy. And certainly there are increased risks that are associated with obesity in pregnancy. But does that mean that you shouldn't get pregnant if you're overweight? And the answer is, well, I would suggest, you want to optimize as best you can. But that is not a reason to stop yourself. But from a male standpoint, as long as we've got sperm, we can put that sperm to work. Well, folks, I think we are going to run out of time here this evening. It is such a pleasure to be with you, and I certainly appreciate the fact that you would take the time to spend a little of your evening with me. As I am fond of saying, oh gosh, I just got a good question right there, and I just was about to sign off. So you know what, Cassandra, I'm going to answer your question. Does Clomid and HCG have side effects in men? My husband's feeling sore and no energy. My husband and I are currently in treatment at MCRM with Dr. Allering. My husband is a 2-time childhood cancer survivor, and outside of treatment, he does take a testosterone injection. We know the odds are against us, but we're hopeful to find sperm. Well, sometimes in that scenario, that Clomid can help him build some sperm. There is a wonderful protocol that we can use to help men who have been on testosterone to try to get their bodies to start making testosterone again, and so we can certainly help with that. Clomid is a part of it. Clomid is an anti-estrogen, and that anti-estrogen can also kind of make you not feel so good either, but it will ultimately be able to boost his testosterone. So it may be that he's had a little dip there, and now hopefully it's on the way up. Maddie May, thank you for being here. Just had your first appointment today, and looking forward to meeting you as well. And you're in Panama City. Awesome. This whole fertility business is not the book of your life. It is just a chapter. That's it. And what are we doing? We are here to rewrite that chapter together. So every day forward, every foot forward with love, every foot forward with kindness. The world is not a kind enough place. By the way, join me again next week at 5:30 for the Fuzzies with Fink. Send out those good vibes to everybody who needs it. And remember, every day forward with hope, because tomorrow is a new day and it's full of all new adventures. So until next week, I'm Dr. Randy Fink. This is Fertility with Fink. Thanks so much for being here. Good night.